Hi, good morning, everyone. Welcome to our 143rd live session on cmaao weekly meeting. We meet every week for a topic which is important for this, uh, which is important for this scenario. And uh, we are national medical associations which come across and come and discuss about the regular topics. So today we have Dr. Ramamurthy Bingi. He is discussing on primary prevention of cardiovascular disease. He's an MBBS and DM cardiology, interventional cardiologist at Being Heart Care of Fidelity Center. Sir, over to you.
Thank you. Thank you very much. Am I audible that side?
Yes, sir.
My slides are also visible. Thank you very much for all your effort. My special thanks to Bukhari also. I am seeing very good eminent friends, Kiran, Prakash, Akhtar, Manohar, Mulazim. I will be touching upon a very important topic. You go to any textbook of cardiology, the present day chapter starts with the preventive strategies of the heart disease. We know that there is a lot of advances that are taking place on the drug therapies, drug trials, interventional cardiology, and the like. But prevention remains a fundamental aspect of the cardiovascular diseases. And we have a role starting from the general practitioners to the matured cardiologists and retiring cardiologists also I'm including in the primary role of preventing the cardiovascular disease. Cardiovascular disease prevention basically consists of three types: primordial, primary, and secondary. I'll be touching upon the fundamental aspects of the primary prevention of cardiovascular disease. This is a very interesting slide which I am trying to share with you. This shows the extent of having a 5-year cardiovascular disease per 100 patients that we look at, starting from the cholesterol levels, smoking if you add, and then you add an different age groups, and you can make out the so-called traditional risk factors, what we constitutes as an cholesterol, hypertension, cigarette smoking, and the like. They have a tendency to increase in their effect and also multiplicative effect when they are together. The fundamental principles of managing this is basically the risk operates across a continuum. As you saw in the previous slide, the more the cholesterol, more is the risk. Similarly, more the hypertension, more is this. Can I come back to the previous slide? Previous slide.
Sorry, can you go to the previous slide?
Yeah. So as I was trying to say that risk is a continuum and the risk factors often cluster together. It's a very interesting phenomenon. See, we have observed in our clinical practice, blood pressure and cholesterol and, other bad habits, all of them, they remain more of the time together. If you take a simple example of a diabetes, we have recognized almost 50% of the population is having an associated risk factors in the tune of about 50%. And risk factor also multiplies. We have recognized that also. And the more the number, they try to have a synergistic effect. And the events, what we see in the various studies, in absolute numbers arise in people with the modest elevations, somewhere between 200 to 240, their risk is much more common. And the preventive strategies, whatever we are adopting, both at the individual level and as well as community level, are quite affordable and they're quite cost effective. And thus, preventive aspect is a very important aspect. One of the first South African study suggested the family history and obesity as the most important risk factors. In India's study, we had a high incidence of insulin resistance and metabolic syndrome, which were contributory. there were a lot of studies which tried to dichotomize between the urban population and the rural population. We also noticed that there is a psychological stress, birth weight, socioeconomic conditions, and particularly some of the psychological psychiatric diseases like depression and anxiety are all involved with the incidence. So it is beyond the conventional risk factors we should try to go. One more study, that is urban population study in Chennai, emphasized in the Indian setup, the obesity and metabolic syndrome probably may emerge as the most important risk factors. World Health also reported that the importance of fruits and vegetables and physical inactivity, which can be easily modified by preventive strategy. And I stressed upon about the acute stress and the chronic stress part and the depression part also. Again, they all can be prevented by proper counseling. Next slide. Can I go for the next slide, please? Yeah. Cigarette smoking should not be taken lightly. Whether it is an open smoking or a discreet smoking, both active and passive smoking habits are important. In a Singapore study, the analysis of the patient's autopsy studies, they showed that there was more than about 50% of them having triple vessel disease. And the best part of that, if you insist on these people to stop smoking, by the end of 3 to 5 years, you can expect they come under this so-called normal bracket. And the more number of the cigarette that you smoke, the effect is more seen. And it is multiple actions: platelet action, vasospasm, endothelial dysfunction. These are some of the important things that occur apart from the hemodynamic effects of the nicotine that are responsible for the premature heart disease. Next slide. So here again, one of the slide which shows that the body mass index. I was started to see some of the youngsters recently when I went to one of the convent school. There is almost about 30–40% of the children are overweight and obese. So it is going to be a very big problem. And those of us who are thinking in terms of preventive cardiology should keep it in mind. As you see in this slide, as the body mass index increases, the CV risk increases, and thus we should be defining. In fact, there have been a lot of attempts have been being done to redefine really what should be the waist measurement, what should be the hip measurement in the South Asian population. They appear to be a little different from the Western population. Next slide. I'm not going to highlight about those things. As I said in the beginning, these various risk factors have that they often run together. That is known as the clustering, and they have a synergistic effect and amplifying effect, and they can be prevented. We all are known about one study, Salim Yusuf and his group, that is the so-called inter-heart study. And here also we saw that risk factor directly similar in almost all the regions of the world and all ethnic groups. There is nothing like an British people have a different and Asian people are different. And this suggests that approaches to prevention can be more or less based on simple same principles all over the world. And majority of the risk factors are related to the lifestyle, and thus change of lifestyle will help in the modification of these factors. And the lifestyle modification is most important factor that we should understand. We should follow to practice it and also recommend to the people whom we are trying to care for. Next slide, please. Next slide. Yes. Now here is, as you see, come back to the first slide, previous slide. Yes. Here, as you see, the benefit of clinical outcome studies, which we have been listening to, whether it is in terms of lipid modification, lifestyle intervention, BP lowering, glucose lowering, all are possible to maintain an optimal CV risk reduction. Next slide. I would like to, next slide, please. This is a little darker, you may not be able to see. Yes, this was this is a very popular study which came in the year 1994. Is a community-based study. They try to emphasize over a period of almost 10 years period, looking at the various association of the risk factors like smoking, blood pressure reduction, cholesterol reduction, and if you combinedly do all the three factor reduction, you make out almost about 50% reduction in the total cardiovascular disease. It's a very important community study, and I would emphasize this, that modification and primary prevention definitely has a role to be played both at the community level and as well as individual practitioner level. Next slide. These are the ABCDs of prevention. One is, of course, there are some drugs. I will try to make a passing remark. Aspirin, ACE inhibition, and reduction of the sugars, BP control, cholesterol lowering, diet, don't smoke, reduce the new onset of diabetes. Diabetes is becoming a very rampant issue in the Asian countries. Exercise, of course, A, B, C, D, E. This simple alphabet we remember, I think we will be able to execute the preventive strategies well. Now, as I said, the diet is a very important one, dietary modification, apart from the physical activity. And starting from the year 2002, we had the physician's health study, nurses' health study, and cardiovascular risk studies, European prospective studies. All of them emphasize that the diet has a very important role to play. So we are basically more of a cereal eating people. We have to change our pattern. We do talk about the Mediterranean diet. We talk about fasting diet and so many things. I think the fundamental principle is we should eat more and more fruits and vegetables. Next slide, please. This is then multivariate relative risk reduction for coronary artery disease, which came from Joshipur et al. As you see, number of fruits and vegetables intake, if it goes on increasing, you can definitely reduce the cardiovascular coronary artery diseases. So it is these fruits and vegetables not only are important in terms of hypertension and other things, but also important in preventing the cardiovascular disease. So the dietary modification is very important element. Next slide. The diet, proper intake of the diet is a very important one in the control of diabetes onset also. We know that diabetes is a sort of a continuum, starting with the metabolic syndrome, then ponderal obesity, then onset of diabetes, adult onset diabetes, and the like. So it is quite possible we should have a proper food choices and activity choices in the managing of the diabetes, because diabetes is, in fact, though it is not considered as a major risk factor in the Western studies, it appears to be a very important thing because it brings along with so many metabolic problems, issues, endothelial dysfunction, hypertension onset, lipid abnormalities, and thus we have an important role to play in a diabetic population as far as the prevention of cardiovascular disease is concerned. Next slide. Now, this is a slide to show which came in by Fang et al. As early as 2005. In an epidemiological study, they recognize that the exercise reduces not only cardiovascular disease, but also all-cause mortality, as we see in this case, normal blood pressure, pre-hypertension, hypertension population. And it is immaterial whether they have a normal blood pressure or hypertension patients. Exercise does definitely reduce the cardiovascular mortality. Next slide. And 2000 report, 2005 report, all of them, they said the same thing. At least about 30 minutes of physical activity, moderate activity, eating fruits and vegetables, and having at least about more than equal to more than 9 servings. In an economically developing countries and poor countries, it is very difficult. At least 1/3 of our plate should have some amount of vegetables and fruits. Next slide, please. Controlled trials which performed among both the men and women, they showed that the vascular disease cannot be in any way prevented or protected by the use of vitamins, B vitamins. This is a very important thing. There was a time when there were a lot of noise was raised and made for the supplements of vitamins, particularly B vitamins and vitamin E and all that. We do not have any evidence to say that, but as a regular nutrition supplement, they can be allowed. Let us now, apart from that, in primary prevention, in a normal healthy person who has not manifested a coronary artery disease, is there a role of medication? We have some evidences to say that. I will take you along some of the slides here. This is an HPS study which showed that the reduction of the baseline lipids and immaterial of the baseline lipids and diabetes status, there was a reduction in the cardiovascular mortality. So that doesn't mean, that means there is a significant role that can be played by the lipid agents, lipid lowering agents as a primary prevention. But there is to be a line has to be cut off, whether it has to be for the patient with a very high level of cholesterol, with another family history or something like that, physical inactivity being there, and to be used in every case who comes some particular age to use the lipid agent. This is a very important discussion, which I leave to my colleagues to later on session. Next slide. This is another very beautiful Anglo-Scandinavian study which showed almost 36% relative reduction over a period of 5 years by the use of atorvastatin. Of course, this was a population of hypertension, but we can extend it to non-hypertensive populations also. Next slide, please. Is there a role for aspirin? This has been talked about as a primary prevention. Secondary prevention, there is no doubt about it. But primary physician health study showed some amount of myocardial infarction and strokes are concerned. There was a definite relative reduction was there, but at the same time, the risk of chronic GI bleed and chronic anemia induction, chronic gastritis problems are very well known, and thus overall now the recommendation is not to use the drugs like aspirin. Next slide. Now we have been listening once in a while about this. There was a lot of noise done about 5 years back. Now it has come down a little bit. The concept of the so-called polypill, combining some of the medications which have been time tested like ACE inhibitors, aspirin, and a statin, and use them. But again, now the conservative physicians say, no, instead of using a polypill, you better use a component because you are capable of titrating the medicine depending upon the situation. Next slide. And of course, a significant role is there for preventable screening and health checkups, like detailed examination, blood tests for lipids and sugars, ECG and echocardiogram, treadmill exercise, ECG, myocardial perfusion tests, CT and MRI, maybe in selected cases, coronary angiogram also. But these are all under the dispute for a healthy person. Even when you look at the so-called health checkups as a screen checkup, the yield of the checkups for the amount of money that you spend may not be that great. So there are some people who are saying there is no role for that. We have to have a particular age group beyond which we should be able to do the screening rather than for each and everybody. And there is also a question being raised about the role of a treadmill test in a healthy person, the role of CT coronary angiogram. These are all debatable and questionable things. At least minimum investigation health screening can be done in those who are above the age of 35. We have reduced the age group from 45 to 35 years in Indian population because Indian populations are very prone to have the sudden death syndrome quite commonly. So we were able to pick some familial diseases earlier, familial hyperlipidemias, diabetic tendency, pre-hypertension status, and the like. And thus, preventative screening and health checkups, they have a definite role to play. Next slide, please. There is a role to be played not only by the doctors, but also policy makers as well as the ministry. I am not going to talk about much about them. As we have known, other than the conventional risk factors, there are many more unconventional risk factors emerging. The role of inflammation is coming in a big way. Air pollution is coming in a big way. Psychosocial stresses and psychiatric diseases are coming in a big way. So there is a proper role to be played by the government and other policy matters also in preventive strategies. Next slide, please. This is, we have seen that in Southeast Asian populations, the cardiovascular disease is quite early, again emphasized by the Inter-Heart study. So protective factors were lower in South Asian than other countries. What I mean to say, like, for example, HDL cholesterol was low in the Indian population. And similarly, we saw that the less moderate or high intensity exercises is more prevalent in the Asian population because they're all pressed for the active, pressed for the work and earning, bread to the mouth, and they spend very little time on exercise. We should emphasize that they should do some amount of exercise. And we have also recognized the fruits and vegetables are less. And there are some other parameters, abnormal lipid parameters. Other than that, low HDL being quite common, ApoA1 ratio is quite often changed, and there is an LPA is high, homocysteine levels are high. Some of these things should be kept in mind in formulating the preventive strategies. And of course, we have more incidence of diabetes. That is also another important point should be kept in mind. Next slide. Next slide, please. Okay, next. Okay, I think this is the last slide. So I have tried to emphasize the individual role that has to be played, as well as the institutionals that have to play the role in preventive cardiology, how we should start doing health checkups very early from the age of 35 onwards, and the role of various common risk factors and how we can handle them as a multi-factor risk intervention. A multi-factor risk intervention trials have come up in diabetic population, but non-diabetic population also we should keep it in mind. And apart from that, in selected cases, the role of statins and role of aspirin in some cases above the age of, which are so-called high-risk population to develop CVD. In some of them, we can use them. So there are some drugs definitely are beneficial, and we can follow this sort of a preventive strategy, knowing that the common things occur commonly and they can be prevented. I think we may be doing a lot of service in primary prevention of cardiac. I have not touched upon the secondary prevention. I have touched only on the primary prevention. A normal walking around healthy person below the age of 45 or so. Thank you very much for your patience here. Any questions I'll be able to ask.
Thank you, Dr. Ramamurthy Bing, for the wonderful presentation and enlightening us for the topic. I would now also thank Dr. Bukhari for sharing the slides at the last moment.
Thank you, Bukhari. My special thanks to him.
You're welcome, sir.
He's always ready to help us out. So we will open the round for question answers. If anybody has questions, kindly raise your hands and ask directly.
May I start the question, sir? May I ask
Sure.
the question?
Go ahead.
Sure,
Sir. Thank you very much, sir. Sorry, sir. For such a nice presentation about the very common diseases, and not only in the world, also in Pakistan and India. So we are living in the same diet factors and we are having the same risk factors. What is the role of hyperinsulinemia in risk factors? And if we control the hyperinsulinemia, can it prevent the cardiac diseases?
You are talking about homocysteine, sir?
Hyperinsulinemia.
Hyperinsulinemia, right.
Yes, yes. Yes.
Hyper is a very important risk factor. There's no doubt about it. Before the onset of the so-called pre-diabetes status and diabetes status. But we do not have any particular dietary intervention or a drug intervention targeting only the insulin and see that it is in the long term helpful in the prevention of diabetes. I do not have any research. What about you? You know, if you know anything, you can share with me.
No, I was listening one lecture in the interventional cardiology, and they were telling that no doubt the hyperinsulinemia is related usually in the diabetes, but also it controls if your insulin becomes normal level, your blood pressure can become normal, and if your blood pressure is normal, one of the main risk factor of the cardiac diseases can be controlled. Yesterday I was listening in the topic that I asked you, sir. Thank you, sir.
Oh, so nice of you. Thank you very much. That is true. The exercises, we have found out that the major role is, of course, in the endothelial function improvement, but at the same time, this balancing the insulin hormone versus antagonist of the insulin is a very important element also. That's how it helps, I think. It's a good point that you raised, sir. Thank you very much.
Dr. Hussain, you have a question?
Thank you, Sharab. Thank you. Very excellent presentation. I just concerned, our population group all over the world, the role of garlic can prevent the cardiac disease. Oh, can you share your experience about the garlic?
Yes, sir. There were some efforts were made to look into that garlic extract, garlic supplement, and the like. But we have recognized the garlic does definitely has a role in reducing the triglycerides, and it improves the HDL values also. But once I remember one of my colleagues made a comment. The eating of the raw garlic. At least about 10 to 12 parts, it is beneficial. But the thing is, it's very smelly and the people hesitate to take that. And this has been exploited in different directions, like, heating the garlics on the tawa and then eating it. By the time that nutrient effect goes away. And the people have also made in terms of the capsule, it came into the vogue and then it disappeared. I don't know much about it, sir.
Thank you so much.
Thank you, sir.
Dr. Ramanmurthy, there's a question from our audience where they're asking about, somebody who is a patient of diabetes or a hypertension, what precautions they should be taking while they're hitting the workout sessions or the gym, and somebody who is not a patient but has a family history of having diabetes in the family or hypertension, because these days we have heard a lot of news coming in where people are scared to hit the gym and workout sessions because a lot of deaths are happening during that time. Obviously it is not because of the workout sessions, but it is because of what disease you are carrying in yourself and what triggers out at what kind of exercise. So anything you can enlighten us for this?
That is a very interesting question. Very nice of it. When a person is already having a diabetes and hypertension, they are more synergistic and they are definitely maybe an intercurrent IHD, which is unrecognized. We should, if you are trying to do it without an structured evaluation by a treadmill test, you go slow and low. If you are trying to help only the diabetic status, if you really look at about 30 minutes of a regular walking exercise, enough, they say, to change the metabolic trend. To prevent the cardiovascular disease, we expect about 40 to 45 minutes of exercise. If you are trying to control the obesity is the important factor, you should do more. But when you are going more and more, the simple principle is go for more of an dynamic exercises rather than the isometric exercises like walking, jogging, cycling, and the like. For the persons who are hitting for the first time the gym, it is preferable we have an health checkup. There is no harm if you do a treadmill test, which hardly costs you about 1,000 to 2,000 rupees in you know in city areas, and that will give a little knowledge how you are able to do that. Because many a times you may not be able to get a personal trainer. You better have a treadmill test and then start hitting the gym. And sudden deaths are quite sensational news that has been happening. And if you are able to afford it, again there mix it with the gym dynamic exercises with a more of exercises, and preferably you have a personal trainer in the first few months also. It is good.
In fact, I remember Dr. K.K. Agarwal used to talk about 6 minutes walk test for a regular daily routine for people who cannot even afford. It's a test which is free of cost, available for everyone. And it tells you about your heart condition and your lung conditions. So he used to always emphasize that if you can walk for 6 minutes without giving any stress to your body and without getting tired for at least 500 meters, and then probably you don't need to worry, but you can still have your evaluation done, but you don't need to worry. But if you cannot walk, then you should consult your doctor immediately.
That's a good point, because you are trying to know at least the base level of the cardiac status. But India is India. If you just tell them 6 minutes, they'll stick on to the 6 minutes only. Okay, we should.
Yeah. No, but that's a 6 minutes walk test, and that's
Is
not your cardiac
important.
exercise.
Is important.
Clarification.
That is true. At least to know the level of minimum physical activity the heart cardiovascular system is able to cope up with. That is a good point.
Okay, so another question which we have is, since you talked about smoking and how it affects your lungs and your cardiovascular problems, what about pollution, and which cannot be avoided? Like you're living in a country where, or in fact, the world is going for a pollution problem. So how is that getting affected for your cardiovascular problems, and how can you safeguard yourself?
Pollution has been definitely found to be an important risk factor in the epidemiological studies. And for a person living in a place like Bombay or Delhi, where pollution, even including my own place, Bangalore, nowadays we're seeing a lot of pollution. It is difficult to be doing any sort of a preventive strategy as an individual. This should be taken up in a big way by the policy makers. Give more and more maybe green grounds, control, try to keep control on the factories and other things. But the humidity and the temperature drops, I don't think we can control them, but we should keep them in mind, what to do. They're definitely.
Does it affect, like, how much
the
pollution is affecting more than a smoking? Like, is that a similar effect, or is that a
I do not have an idea. We did a study here in Bangalore from Jayadeva Institute of Cardiology. We did one lung study from one of the private institute also. We had a very significant effect seen by the pollution, but I do not have an objective correlation with that.
Okay. Do we have any other questions from the floor? Dr. Elvin, do you want to say something? Yeah, go ahead, Doctor.
Yeah, just to need some clarity on non-smoker or passive smoker inhalant of cigarette. What is the percentage of cardiac disease on those population, those who are not smoking but passively inhaling?
I do not have an idea about that. Passive smoking is injurious. We have seen the patient population by the statistics. No smoker, passive smoker, say cigarette smoker in a quantum, say less than 10 or more than 10, like that. But passive smoker, how much he smokes, I do not have an idea. In a closed space, how much he smokes, and if he's alone with one or two friends, how much he smokes, and open area, how much he smokes. I think it's a very interesting topic to do research, I think so. Anyway, it's a good question that you raised.
So I think the best answer for this is quit smoking. So most of the questions get over. And if you're a passive smoker, whoever is your active smoker, ask him to quit smoking.
Right.
So
No, some of the things we do learn by interacting with you like this. It's it's an interesting point. Passive smoker, how much of a smoking load that makes him vulnerable? Has there been any particular study in a closed space versus open space with continuously being over a period of 24 hours? It's a good point. It's a very nice point.
in fact, I would also say that yoga has turned out to be a very important subject for a lot of people who are, having problems, and yoga has really done wonders for people. Not only the physical exercise, but including, what do you call pranayam and all those things. Even for people who are non-smoking and are smoking, it helps you to clean the lungs. Dr. Sajad, you have a question? Dr. Sajad, you need to unmute yourself. Dr. Sajad, can you please unmute yourself and ask your question?
Yes, now it's okay.
Yeah.
Agarwal? Okay. Thank you very much, Agarwal. I just want to know about the effect of shisha smoking, shisha. So how much its effects on the cardiac system is, I think it's a same like a cigarette, and which I know something about that. If you smoke shisha in a shisha cafe for a period of 1 hour, it means you smokes 200 cigarettes. I think it's according to the WHO. So what's its effect? Is the effect is the same as the cigarette smoking? Number one. Number two, my question is that in our society, maybe in India also, we have in Pakistan that most of the people eat in the middle of the night and just doing nothing, just go directly on the bed. So what is your opinion about this habit? The people are taking dinner late, particularly in the gathering, like the marriage ceremony, the dinner served in late in the middle of the night, and then after that they go straight directly into the bedroom. So what it affects on the cardiac system? And my first question I have already asked. Thank you very much, Bimji.
Thank you. Both are very interesting questions, and I learned from you the shisha smoking gives so much of almost like 100 cigarettes, something great. We had some studies also come from the indirect smoking, like in Andhra Pradesh area they do what is called the chutta smoking. They have done some studies, and they also found that there is a significant amount of nicotine and as well as the non-nicotine effect, and there is a disease. This is a very, very interesting point. Whether it is an rolled cigarette or a rolled chutta, or it is an indirect chutta or direct chutta, all of them are the same effects, I think so. It's a good point you brought out. Another important point is, sir, it's a very nice point you said. Why about Pakistan? Why about Punjab area? We are seeing it is a world phenomenon now. It has become, particularly in the developing countries like India. Here we see the eating habits and sleeping patterns have changed. Most of the people in a place, I'm trying to give an example of a Bangalore. They try to eat in the afternoon somewhere nearby a hotel, and in the evening time when they mix up with their family members, they eat heavily and just watch the TV, or sometimes without watching the TV, they go to the bed. I think this sort of a pattern is particularly bad. When one of my diabetology colleague was telling me soon after eating, within about half an hour or so, your glucose levels and triglycerides levels will start rising. And in order to cut them, it is better if they do a little bit of a walking, about half an hour or so, before going to bed. I think we should try to emphasize this point in our day-to-day practice. Any other questions, sir? I will be able to happily answer, or if we any other.
Do we have any other questions on the forum?
Yes, sir, Sajjad has raised this.
Dr. Sajjad has already asked his question. Anybody else has a question?
I think, Sajal, I have given you satisfactory answer, or you feel like adding anything else for the late eating and sleeping?
I think life teaches us that, sleeping habits and your eating habits should be on the same time and the same way for living longer. Dr. Sajjad, if you're trying to speak, you're muted.
Dr. Kaisa Sajjad.
Automatically muted. So now it's unmuted now again?
Yeah. Please go ahead.
Okay. Thank you very much. You have answered very satisfactorily. I have a lot of questions, but this is my last questions. That my observation is my friends and my other fellows. I played cricket, and a concept is then that if you are routinely doing exercise, doing regular walk, involved in a outdoor activity like cricket, football, hockey, something, so you will be very healthy. But my observation is, but it's very few one, that few of my cricketers are playing cricket, and during taking runs they fell down and died. I observed that one of fellow who's walking early in the morning daily, and during walking one day he fell down and then expired. So what it is? It is something other problems, or what it is?
It is probably the same thing, that is acute plaque ruptures and producing an acute coronary syndrome. We do think that the treadmill, doing exercise, vigorous exercise, and then afterwards immediately taking rest, some of them are responsible for. It is quite possible because of this catecholaminergic surges, this plaques do rupture, and then that is how the incidents happen. And this sort of a phenomena has been happening both during exercise as well as after the exercise. But in young people below the age of 30, 35, we can keep it in mind some of the cardiomyopathy diseases also, like hypertrophic cardiomyopathy or dilated cardiomyopathy. Some amount of familial arrhythmias also, arrhythmia syndromes. But majority between 30 and 40s, we have seen that is because of plaque ruptures, acute coronary syndromes only.
Okay, thank you very much.
Thank you, sir. Thank you.
Sure, Dr. Ravi, Dr. Prakash, anybody else has a question? Otherwise, we'll wind up the session.
Nothing from me, Saurabh.
Okay. Okay, so thank you everyone for joining in for this session. If you have any questions, please do write on the comment box, or you can send the questions to me and I will be happy to respond asking the expert. With this note, we would like to end this session. Thank you so much for joining in for this session. I hope this session was useful. See you again next time. The dates will be announced shortly. Thank you so much, Dr. Ramamurthy, and thank you so much, Dr. Bukhari, for
colleagues here who participated.
Thank you so much for a nice presentation.
And my special, thanks for you, because you helped the program to happen.
Thank you, Dr. Bukhari. Thank you.